Hello, it's my pleasure to talk about
Здравствуйте.
transvenous arteriovenous
Очень
malformation
приятно
embolization,
побеседовать с
the
вами
concept
сегодня о
of total flow
трансвенозной
control.
стимуляции во время трансвенозной
Here are my
эмболизации
disclosures. They're available
информации.
online.
Здесь оговорки, которые вы также
So,
можете найти
without going
онлайн.
into too much detail, clearly treatment for AVMs is multimodal, and we need to all appreciate that that includes all different varieties and combinations of arterial transvenous embolization, radiosurgery, microsurgery, and all of the above. When I think of an AVM, I think of this example that I've really picked up from René Chapeau and Charbel Monaya, where they talk about it being like a broccoli with individual components. And I truly believe that is where the disease is, and these venous chambers empty the disease aspect of it, and there can be complexity with multiple veins draining. But generally speaking, this is the pathology. And what we need to address is occlude these nodal components. And the arterial supply many times is useful, but it's not always the best way. And so that's what you're really looking for when you're looking at an AVM, whether by angiography, identifying components, or by MR, the same concept, identifying these individual components, so one can then come up with a strategic plan as to how to manage this. And so here's a really good example of one of these cases that we may show later during the presentation, where you have, this is the food plant of it, and these are these individual venous channels which are draining this into a primary vein, and that can have significant import. Then you can see the arterial aspects themselves, as well as the venous channels. The large ones are quite unremarkable in terms of variance from normal. So when I think of the things, and this is sort of talk purely based on what my perspectives are, this is deciding whether this AVM needs to be treated, and there the primary effect is, can I treat it? What's the combined procedural risk? And is it worth treating it given the patient's age and comorbidities? It's a combination of those two factors rather than some dogmatic interpretation of Aruba. So if the AVM is on the external surface, I tend to consider arterial embolization of difficult to access feeders. Rarely, maybe 1 in 7 or 8 cases, I might endovascularly cure it, but I'd be prepared for surgery, and most cases will go for surgery prior to completion. If, on the other hand, the lesion is deep, then my strategy is very different. I'm trying to reduce nodal volume. I think that's really important. And again, prepared for endovascular cure. If it becomes imminent, still get prepared for surgery. We can get access to all different parts of the brain. Really, that's sort of the mainstay till I started seeing these reports. My first introduction was with Istvan Hudak, this incredible, eccentric, somewhat, interventional neuroradiologist from Hungary who opened my mind to this transvenous, and then Charbel Monayer started reporting, and soon thereafter René Chapeau started doing this, and really there are lots of different ways of doing it. There's a pressure cooker technique which has really been advanced by René Chapeau, whereas Charbel talks about the porcelain vein, and there's some early meta-analysis suggesting a much higher cure rate, but with a clear risk profile which may be potentially lower than the transarterial cure rates. So for me, if the AVM is on the brainstem or considered high risk for both microsurgery or radiosurgery, and right now I'm tackling multiple single veins, I try to do arterial embolization first, that's always first, and then try to reduce the flow without getting a lot of nodal penetration, and then bring the patient in for transvenous embolization. And in that regard, I stumbled on something that I'd heard about, cardiopulmonary bypass to reduce arterial pressure, used by Charles Drake here for complicated vascular aneurysm clippings. But then talking to my friendly cardiologist here at the Gates Vascular Institute, where I was thumping my chest on using adenosine, I was informed that it is incredibly archaic to do that. I should consider transvenous
взял
spacing. And I did a
узнал
few
о
cases
замечательным
and thought,
подходом с
wow, this is a
трансвенозным
significant
стимуляцией. Я
contribution by
понял,
me,
что
till I
это
realized,
замечательный
well,
вариант и дополнение к
it
тому,
is
чем
a
я
very
занимаюсь.
simplistic
И
technique.
здесь
It takes very
достаточно
few
упрощенная
seconds to get this
технология,
in the right
требуется
place.
несколько минут
We
для того,
typically do
чтобы
this transfemoral.
все это
And just
можно
when I
было
thought we'll collect
ввести
a
в
series and bring this to the
нужную
world,
позицию, как
realized that
правило,
this has already been done and well
трансбедренным
described by
доступом
this
вот
Belgian
используется,
group,
и все
where
это
they really beautifully
хорошо
demonstrated
разработано
the
вот этой
value
бельгийской
where you're
группой, хорошо
reducing
описано,
their blood pressure,
преобразно
but you're not
показано, каким образом
eliminating
уменьшается
enterograde
здесь
flow. So
давление,
for all concerned, the
но
fundamental
при этом
difference,
фундаментальная значимость,
the fundamental difference between
разница
adenosine versus venous spacing is adenosine causes complete halt of circulation. Spacing does not cause complete halt. There's still flow, but the blood pressure is much lower. On the bad side, adenosine only results in variable in a few seconds, whereas here this can be sustained for up to 60 seconds. You just got to be mindful that when you're pacing, the heart's not getting blood either, at least not at high enough pressure that it should therefore we typically don't go beyond 60, in most cases don't go beyond 30 seconds at a time. So, in terms of how we do it, if all our patients are evaluated from a cardiac disease standpoint, they get their cardiac clearance evaluated by the cardiology team. This is under general anesthesia, burst suppression to reduce CMRO2, fully heparinized, and then we usually will have arterial access for balloon occlusion of the parent vessels or territories, and sometimes multiple balloons. And then we have jugular access for actual venous access for the brain, and femoral vein access for venous spacing. We typically have two catheters, one for the onyx and the other for coils in blue. And usually we do this with two interventionalists. We typically pace at 180 to 200. We test that before the procedure to see exactly where the mean arterial pressure will drop. And we typically try to limit arterial balloon inflation to 5 minutes. And we will typically coil 1.5 centimeter vein proximal to the onyx catheter, and then we'll prep the onyx, and we typically prep the NVCA catheters as well, but we continue to inject the onyx so we see reflux through the coil mass, which is the point at which we inject NVCA, and we start pacing with the first pace a little bit longer and thereafter shorter periods of time. And the cardiologist calls these volumes. And it's done pretty quickly. And the onyx fills the coil mass, and then we inject the NVCA. We typically have 80% glue for that. And we just continue to inject till we really feel there's no reason to inject anymore. And it may even have a small venous rupture. In fact, I was just doing a case flat with WNC, and you could actually see that that's the point at which I said, okay, I think we're done. And then, ideally, you want to confirm through multiple arterial microinjections before considering the NVCA catheter is removed early, the balloons are removed. However, the onyx, which is deep in the AVM, we'll try to see if it easily comes out, but half the time it comes out easily despite the NVCA. If it does, you just pull it out. On the other hand, if there's any tug, you can cut it off at the neck at the entry site. And that works well. So a couple of quick cases in the last few minutes. The 29-year-old comes in with symptomatic, however unruptured Alvernian AVM with a feeding pedicle aneurysm. There you can see the feeding pedicle aneurysm. You can see the complexity of this Vernian AVM, large, with lots of arteries and veins supplied by probably all vessels. So we go ahead, stage one, we coil the aneurysm, and then start embolizing with SCA, which is starts allowing us to appreciate the anatomy a little bit further. Then the next embolization is through pica, and with each successive embolization, we see anatomy better, we see veins better. So force embolization left SCA because we have bilateral supply. you're now starting to see these primary veins draining into this tertiary vein. So it's starting to allow you to evaluate the venous anatomy of this AVM, and then we went to the pica, and then again, with each successive embolization, we bring the patient back in, and then you can see there's the final vein, and then they have these primary veins draining in, and we get arterial access. There's a septal balloon in the arteries. There's a venous access. There beautifully you can see all these individual primary veins, and there is where they're all coalescing. This is the part that we really need to occlude, and we get pacing started at 36. This is the final result, which really shows excellent residual occlusion. Here's another case, AVM, 18-year-old came in with intraventricular hemorrhage, and we do ventriculostomy. Patient is called mild left hemiparesis, and there's the left lateral posterior choroidal AVM fed up the posterolateral choroidal. There you can see the venous anatomy draining through probably at least partly basal vein. And so there you can see filling from the anterior circulation. So we go ahead and we go ahead and embolize this by getting a microcatheter in the right place, and then we go ahead and embolize, and once we're done, we have reduced the flow, but there's still a little bit of filling, and you can see this perivenous filling coming out of the AVM. So you let the patient cool down, get the EVD out, the patient does well, and mild left hemiparesis. So we brought the patient back. Again, we do transarterial and transvenous. You can see still some filling of the vein. And then we go for the septor and the PCA to make sure we have microinjection ability. There you can see the microinjection showing the vein, and then we go ahead with venous access and get the vein catheters in the right place. And so there's a distal, which is the onyx catheter, there's a balloon, and there's a proximal catheter to coil with venous spacing. Right there is the balloon tip venous spacing catheter. There you can see balloon is inflated, pacing is on, coils are in, and then NBC is injected. Once that is done, you start injecting onyx, and that cures it. And that is the final result. So I think this is, I'll skip these last few things to talk about transvenous embolization should remain reserved for AVMs where other options, including transarterial surgical or radiosurgical options, are higher risk. Transvenous should start with transarterial and staged if needed. Total flow control, I believe, is really important, especially when you encounter a complication during a procedure. I think total flow control really makes that much more manageable and improves the outcome. These are done with general anesthesia with burst suppression. Balloon arrest in the major artery across the ostia of the vessels that are feeding it, and then occlusion of the main vein with NVCA to prevent reflux and promote transvenous tunnel penetration, and rapid complete metal operation. Thank you very much.